Our topic for this session will be emergent complications of hepatic cirrhosis. Our first case is hemosiderosis related to sickle cell anemia. Obviously, this one is not emergent, but all the same, it's such a great example. You can see here the nodular liver contour and the marked density of the hepatic parenchyma related to chronic transfusions and hemosiderosis. Note, of course, also the diminutive and densely calcified spleen consistent with autoinfarction, typical of sickle cell anemia. We can again appreciate the nodular contour of the liver and the hallmark finding of sickle cell anemia, a cholecystectomy, related to densely calcified bilirubin stones. There is the autoinfarcted spleen and the cholecystectomy. Note also here you can see nascent ascites manifesting as mesenteric edema, and you can most likely appreciate early enteropathy as well, manifesting as bowel wall thickening. So that's a case of hemosiderosis related to sickle cell anemia. Our next case is a pretty straightforward varices case to demonstrate cirrhosis with portal hypertension. You notice here a marked large tangle of esophageal varices. Farther down, you can appreciate gastropatic or hepatogastric varices and the nodular contour of the liver denoting cirrhosis. Farther down, you can see in the portal and pancreatic region, these varices are quite extensive. And of course, again, the nodular border of the liver is appreciable. The thing I want to point out about the splenic varices is that they are often associated with this, a splenorenal shunt. This is a portosystemic shunt where the splenic varices will ultimately communicate with the left suprarenal vein and empty into the left renal vein. We'll see that on this upcoming movie. So here are the esophageal varices and the hepatogastric varices. But let's look specifically at that splenorenal shunt. So you'll pick it up here, that prominent vessel towards the posterior aspect of the circle. And as we follow it down, you'll see it pass the left adrenal gland and empty ultimately into the left renal vein. So a classic splenorenal shunt related to chronic portal hypertension. Our next case is a chronic portal venous thrombosis. You can see here marked enhancing varices in the esophageal region. There's enlargement of the caudate lobe consistent with cirrhosis, and obviously there is marked splenomegaly. In the portal region, you can see a central filling defect. Simply based on that, you might call this acute, although we will see on the movie this extends farther up into branches in the liver and could be appreciated on previous studies as well. So it is in fact known to be chronic. And again, the marked splenomegaly. Note also the prominence of the lesser vessels in the portal region, certainly the hepatic artery, but also a number of small portal tributaries. These vessels will enlarge, a phenomenon called cavernous transformation in chronic portal hypertension. And again, the splenomegaly. Interestingly, this patient has varices about anywhere you can have them, and that includes the perirectal fat. So here you can appreciate the filling defect centrally in the portal vein, but also, as I track back upwards, that it extends out into branches of the portal vein within the liver. And certainly in following chronic cirrhosis patients, the portal vein is a very important structure to evaluate. Obviously, interval thrombosis or progression of a chronic thrombosis can markedly worsen these patients' portal hypertension. Our next case is a spontaneous bacterial peritonitis. Obviously, there are large esophageal varices. There is a great deal of intraperitoneal fluid. On this lower cut, you can appreciate caudate lobe enlargement consistent with cirrhosis, and again that intraperitoneal fluid. But here you can also detect the thickening and enhancement of the peritoneum itself. Lower down we have another good example, splenic varices, intraperitoneal fluid and enhancing peritoneum. And even one more, splenic varices, intraperitoneal fluid and enhancing peritoneum, which you can see circumferentially around this loculated peritoneal fluid. Here on the movie, you can appreciate those varices, the cirrhosis, but look at that enhancement all throughout the peritoneum and a large ventral or umbilical hernia carrying that enhancing peritoneum out beyond the confines of the abdominal cavity. This one was an easy tap, needless to say, right next to the umbilicus there, that did yield a polymicrobial bacterial peritonitis. Our next case is a case of portal gastropathy with hemorrhage. We have the enlargement of the caudate lobe and a fine nodular contour abnormality of the liver. You can see here the pronounced hypodense wall thickening with contrasting enhancement of the gastric mucosa. There is quite a bit of intraperitoneal fluid as well, and obviously the greatest concern here is this intraluminal contrast density within the stomach. It looks as though it may be coming from a focal region, which certainly can be the case in hemorrhage from portal gastropathy, although many of my GI colleagues have described this phenomenon as more of an oozing rather than a focal bleeding. You can see here again manifestations of the portal enteropathy with bowel wall thickening lower in the abdomen and significant intraperitoneal fluid. Here again the bowel wall thickening, hypodense, and present throughout, although in many cases with portal enteropathy, you'll see it a little more pronounced on the right-sided abdominal structures. There is that hypodense thickened wall. Looks like there was an old fundoplication, and there from the inferior aspect of the esophagus or fundal region of the stomach, you can see we have that contrast extravasation consistent with hemorrhage. And now throughout the remainder of the abdomen, you can see again that wall thickening that represents portal enteropathy. Again, a little more pronounced on the right. So that is portal gastropathy with hemorrhage. Our next case is a case of Budd-Chiari syndrome with regenerative nodules and active hemorrhage. So you can see the hypodense nodularity throughout the liver. You've got a narrowed IVC, and the hepatic veins are essentially absent. Here again we can appreciate that hypodense nodularity and marked gallbladder wall thickening. Of course, the list of differential possibilities there is long, but Budd-Chiari is indeed on it. Lower down, you can really appreciate the systemic effects of portal hypertension. In fact, one wonders if these kidneys represent an impending hepatorenal syndrome. In addition, we've got anterior abdominal wall varices, which you'll see lower down come into significant play. In the lower abdomen, one of those large varices has burst and resulted in intraperitoneal hemorrhage, and this is very severe hemorrhage. These patients become hypotensive and exsanguinate quite quickly. This is essentially the physiologic equivalent of slitting your wrists in a warm bathtub. The blood from these varices going directly out into that warm intraperitoneal fluid in these patients who are already challenged from a coagulative standpoint, it's a disastrous combination. So here you can see that narrowed IVC suggesting current hypotension We have anterior varices, and as we follow those down, we'll ultimately see the scene of the crime, which is that bleeding varix. Note there's quite a bit of contrast within the peritoneal fluid. We can get another look at that rapidly bleeding varix. So that's a case of Budd-Chiari syndrome with regenerative nodules and active hemorrhage. Our last couple cases are of neoplasms with acute presentations. This one is a vascular invasive hepatocellular carcinoma. Certainly, we think of these as portal vein invasive, but I haven't seen that many that invade the hepatic veins. And this one, fortunately, does both. So you see it crawling up a hepatic vein right here, this hypodense filling defect. And here in the right portal vein, you can see there's an ill-defined hypodense mass there in the right liver lobe. Markedly nodular liver contour, and here in the right portal vein, a filling defect consistent with tumor invasion. So here's the hepatic venous portion. There is the liver mass itself, and now we can follow it into the right portal vein. Note you can also really appreciate the liver findings of cirrhosis there very nicely. So that is a doubly vascular invasive hepatocellular carcinoma. Our last one is a nice companion case to that one. It too shows a hypodense mass in the right liver lobe. You will note, however, there is a paucity of cirrhosis findings in the unaffected portion of the liver. This contour is relatively normal. The caudate lobe is not particularly enlarged. That is important because you can see here on the edge of the liver what's known as umbilication. That is a focus of capsular cicatrization, scarring and pulling inward, retraction, that can happen with metastatic lesions to the liver. Also note there is a filling defect within the portal vein to further confuse things. It would be easy enough to call this hepatocellular carcinoma with portal venous invasion, and I think that is what many people would tend towards. Certainly looking at the liver contour here might trick you into thinking this was a cirrhotic liver. That is in fact not the case, and once you are aware of this phenomenon of umbilication, there is the portal